Hello, friends. You are back and listening to Behind the Knife. I am Michael Vu, and you know what? It's been a little bit of time here since we've done a transplant episode. So we all got together and said, heck, let's talk about transplant this week. We're going deep into the nitty and gritty of surgical technique today, people. I mean, for this episode, I want you to imagine strapping on a GoPro to an experienced transplant surgeon's head and seeing each knife stroke, each retraction maneuver, each stitch placed in the execution of a successful kidney transplant. Of course, you'll in fact be listening to the technical steps eloquently described to you verbally by our guests, but I'm not kidding about the GoPro thing either. If you're listening to this as a podcast, you'll find that it's actually a video podcast. And we'll also be posting the video to our YouTube channel where you may in fact be watching this. So the operative video, we hope will closely follow what you are listening to. Okay, let me introduce our guest today. First and foremost, we've got Dr. Leanne Daggerford. She's a transplant surgeon at Massachusetts General Hospital and assistant professor of surgery at Harvard Medical School. Accompanying her are her two fellows, Dr. Anushi Shah, one of the first-year transplant fellows, and Dr. Ashley Aaron, one of the second-year fellows. Big thanks to the three of you guys for coming onto the show today. I know that the transplant surgery lifestyle is not always amenable to these kinds of scheduled events, so it means it's a huge deal for us to get you guys on. Thank you.
Thank you.
Thank you.
I hope you don't mind, Dr. Daggerford, Dr. Shaw, Dr. Aaron, if our audience gets to know a little bit more about you before we take that deep dive into surgery. Why don't you tell us where you grew up briefly and how you found your way into transplant surgery?
Great. I grew up in Kentucky and did some school outside of Chicago and then spent quite a bit of time in Nashville, Tennessee, doing medical school and residency before I did my fellowship at Washington University in St. Louis. And then I became a Northerner in some sense and moved up here to New England. I became interested in transplant because of a living donor kidney transplant when I was a second year resident rotating on the transplant surgery service. There's nothing quite like it to see a kidney go from gray to pink and make urine on the table.
So I grew up in New York, went to medical school in the Caribbean at St. Matthews and Cayman Islands. And then I did residency in Phoenix at Valleywise Medical Center, formerly known as Maricopa Medical Center, and then came out here for fellowship. I really got into transplant when I was doing mostly my vascular rotation first, and really just loved doing anastomoses and the maximally invasive side of the world. And endovascular wasn't my thing, so I pursued transplant after I got exposed to it in my transplant rotations.
Awesome. And Dr. Aaron?
I grew up in the Midwest mostly and did medical school and undergrad at the University of Minnesota, which was always this huge transplant epicenter. And that's where I became interested in transplant. The fellows were great about taking us out as medical students and taking us out on donor runs and taking us into the OR. I held a Castro when I was a third year medical student, which was very daunting, but all of it was so much fun. I had such good mentoring and I really loved the change in life for the patients. And that's how I became interested in transplant. And then I came out to the East Coast to train. I trained at Brigham for general surgery and for my ICU fellowship, and then came just down the street to MGH for my transplant fellowship.
Very cool. Well, thank you to you three for sharing your backgrounds. So let's hop straight into it with kind of a clinical vignette. So, this is a pretty classic kind of case, but suppose that you have a 57-year-old female with obesity, hypertension, diabetes, and end-stage kidney disease. She's undergoing hemodialysis through her AV fistula, and she presents for a deceased donor kidney transplant. What are the first things you're thinking about when she comes in and you hear that there's a kidney available that are just going to be, possible hard stops to this whole endeavor from the get-go?
Yeah, so I'll start. I mean, I just have to put out a disclaimer. There's a lot of different ways to do kidney transplant, and every center has a lot of different practices and training methods. And even within a center, all of the surgeons have different methods. So these are going to be the basic principles that are universal, like tension-free anastomosis, hemostasis, positioning, placement. Some of it can vary, but we'll kind of go through what we're most familiar with. And to go back and answer your question about hard stops when we're first presented with a patient. We want to make sure that they don't have any kind of active infection, or check their workup and make sure they don't have any cancers that are ongoing or untreated. And then overlook their cardiac status, any coronary artery disease that would preclude them from the surgery. And then also if they are on dialysis, when they had dialysis last, and if their electrolytes are not amenable to anesthesia, then we kind of have to take a look and reassess.
Okay, let's say that your patient is going to be a good candidate for your deceased donor kidney transplant, because what we do want to get into is drill into the surgical principles and the technique. You're in the OR. There are so many. The kidney transplant is just a rich network of decision-making branch points, starting from when you get the donor kidney on your back table. What are the kinds of things that you are thinking about when you're about to start this transplant? You're looking at this kidney and this patient on the table.
Sure. One of the first things I think is how the kidney looks, the size, what side it came from, right side, left side, and kind of orient yourself around the kidney. Some come with a lot of fat on them, some with very little. So it's kind of important to make sure you get your landmarks straight. And then the location and the number of the arteries, veins, and identify the ureter.
So for kind of the medical students or some of the younger residents out there who might not be aware, what is the normal anatomic arrangement of how many arteries, veins, ureters the kidney should have, and what are some common aberrant variations that you're seeing on the back table?
So normal, anterior to posterior vein artery, we always learn vein artery nerves. Here it's vein artery ureter. And obviously you want single of each, but there's always variations. Most commonly I have seen like multiple arteries, but I'll maybe have Dr. Aaron or Dr. Daggerford chime in here to see if they've seen more commonly other things.
I've certainly seen multiple veins. And I've actually seen a couple double ureters, both in recovering the kidneys and then once having to implant them. So we certainly can have a lot of different types.
As long as the length is good on the arteries, almost all of them can be reconstructed. So rarely do we encounter a problem where even multiple ureters, you just do two anastomosis to the bladder. And for the artery, you have a choice as to if you're going to sew in two separate anastomoses or potentially put them together into a fish mouth, where you actually put the two ends of the artery together to make a one orifice before you sew it in to the recipient. So thankfully, none of these variances that we're describing would stop us from using the kidney for transplant.
So besides variation in the number of tubes coming out of the kidney, what about the kidney itself? What do you do when you find a mass on the kidney?
So you kind of want to evaluate it to see if it's a simple cyst versus something like a subcapsular hematoma, or something more alarming like a malignant mass, and in which case we would try to biopsy it. If it's a simple cyst or a hematoma, we kind of leave it alone and see how it reperfuses and if there is an issue. But other than that, I think that just to make sure that the capsule is intact, and evaluate the biopsy site. Sometimes the site is big and you want to make sure to plug it with a piece of fat or something so you don't have a lot of bleeding. But other than that, I don't think there's anything particular like I look for when I look at a kidney itself.
So in regards to the patient then, let's talk about what choice of site that you're placing the kidney in. First of all, when do you choose the left versus the right groin?
So the right side is easier to expose and do the anastomosis. So most commonly we go to the right side. Obviously, if they've had a prior transplant and this is a redo and the right side has been used, then we go to the left side, which is also fine to do. Rarely we go intra-abdominal if both sides have been used for transplant, or the vessels that we would transplant to have a lot of calcifications or not amenable to clamping, which we would evaluate preoperatively from a scan.
How about those patients who have a peritoneal dialysis catheter in place? How does that change your approach and your thinking?
So in our most common practice for patients that have a PD catheter, we still tend to go to the right side, but we can also use the left side. It wouldn't change the approach. We do take out the PD catheters at the end of our procedure. And that might not be something that's done universally, but at our center, we take them out. And then if they need dialysis after, we would do hemodialysis.
What's the reasoning for doing hemodialysis afterwards instead of peritoneal dialysis if the patient already has the catheter in place?
Yeah, so the best way I understand it, and Dr. Difer, you might have to correct me, or Dr. Aaron, is that we, in case there is any violation of the peritoneum or anything, we just don't want that fluid getting close to the graft, or any kind of spillage into the retroperitoneum from it. So I think it's easier to just take that out and have them go through hemodialysis for a short period of time if they need it.
Okay.
Sometimes the peritoneal dialysis isn't felt to be as efficient for achieving the clearance that's needed after a transplant as hemodialysis is. Now, there are some centers that use it and do it, especially in a pediatric world. Sometimes they're more willing to try the peritoneal dialysis, but in a lot of situations, it's just felt to not adequately clear the electrolytes. And so a lot of places opt for hemo in that situation.
It's very sensible to me. So I want to get straight into kind of the steps of the procedure, and I'll let you guys go from there, starting with whomever, and you guys can bounce back and forth as comfortable. Why don't you just start from patient prep, patient positioning, and tell us how you do this amazing procedure, and keeping in mind that number one, it is challenging to visualize this kind of thing purely verbally. Now, we will have the video available, but some people might be listening to this in their cars, so try to be as precise as possible. And a lot of our listeners are new in their medical education, so giving a lot of broad context over the anatomy and what exactly you're doing from a technique perspective would be super helpful. Why don't you take it away?
All right, so I'll start with the prepping and positioning the patient. We usually have them supine on the operating room table. Our perioperative meds include skin coverage, antibiotics. We usually use NSAID. And induction includes either thymoglobulin or Simulec, depending on the patient. Some centers also use Campath. And then we also give these patients Solumedrol at induction. In addition to that, for prepping, all these patients get a Foley catheter, and then we hook them up to blue-colored antibiotic solution in a saline bag, and that comes into play later on when we're doing the bladder anastomosis. We normally tuck the arm that the kidney transplant the side that it's going to be on. So if it's the right side that we're transplanting, we would tuck the right arm just for retractor purposes. And then after the prep, we'd place Ioban on the surgical field.
So I'm going to just insert here what she's talking about when she's talking about induction medication. So the miracle of kidney transplant really only happens because we're able to keep the recipient body from rejecting the donor organ. And the original kidney transplant, which happened in Boston, so we have to give a plug, happened between twins. But since then, we've developed all of these mechanisms to try and suppress the immune system so that it doesn't reject the kidney coming from a non-self donor, so from the donor. And so to do that, at the time of the transplant, we give what's called induction immunosuppression. And it's a pretty big, heavy hammer of medications that push down on the immune system. And those are the ones that she was describing. So Solumedrol is a steroid we give a high dose IV steroid, and then we give thymoglobulin and or Simulect. And then she also mentioned Campats. So those are just different mechanisms of medications to suppress the immune system. And those are what we call induction because they're given at the beginning of the transplant to induce the immunosuppression. And then after the transplant, these patients all stay on maintenance immunosuppression, so medication that they take every day for the rest of their lives to keep them from rejecting the transplanted organ.
And that induction regimen, that's the first time that the recipient is going to be seeing immunosuppression, kind of the,
Yes. Some people give an oral medication on the way to the operating room, but really it doesn't happen until, until they're in the operating room.
And I'd like to just make sure we clarify that blue-colored antibiotic solution as well. So that is going to be going into the Foley, and it's an antibiotic solution that fills up the bladder, right? For eventually you'll be violating the bladder in order to sew in that ureter. Is that right?
Yep. The solution is just really an aid to the surgeons to try and make sure that the bladder is easily identifiable. The other fluid-filled sac in the abdomen is the peritoneum. We talked about peritoneal dialysis, and it would be a pretty major whoops to mistake one fluid-filled sac for the other, and so the ureter to the peritoneum instead of to the bladder. And so to help us, because we're not perfect by any means, to help us identify that, we use blue solution into the bladder through the Foley that gives us a nice reassurance that we're sewing the urine to the right fluid-filled sac.
Well, that is a simple and clever way to make sure you're in the right spot. Awesome. Well, let's get to the incision then, the good stuff.
So once we're prepped and draped, and for the incision part, we like to go make a curvilinear incision to about 2 finger breadths from medial to the ASIS and 1 finger breadth above the pubic bone. And we make the skin incision with a knife and then take the abdominal wall layers with electrocautery and some blunt dissection. So just to go over the skin, the abdominal wall layers, you have the skin and the subcutaneous fat. After that, you have Scarpa's fascia. And then you run into the external oblique, aponeurosis, and muscle. We go through that, and you have the internal oblique, and then the transversalis. And the peritoneum is right under the transversalis. We usually use most of our blunt dissection here as well so that we don't violate the peritoneum, enter the intra-abdominal cavity. And we enter laterally to the anterior rectus sheath and sweep the peritoneum medially and superiorly. And the native ureter is swept up with the peritoneum. So it'll be out of the area where we would identify the vessels and dissect this plane. And we dissect this plane straight down to the retroperitoneum until we reach the psoas muscle. And when we, if the plane is correct, it should be avascular. But sometimes you have a lot of collaterals in between the muscle and the peritoneum and the retroperitoneum fat pad that there is some bleeding. But we enter this space all the way down to the psoas, sweep up the peritoneum medially and superiorly, and then identify the iliac vessels.
Sometimes with our blunt dissection, some ways to make it easier is we'll just put a bunch of lap pads in there. It kind of does a dissection for us, especially if you're in that correct plane and it's completely avascular. Like 3, 4, 5 lap pads, you'll usually have the size of a kidney. And then after that, it's really just identifying, controlling the iliac vessels.
So once we have created this space, we usually put on our retractors to kind of help us look at the vessels and create our field where we're going to be doing the anastomosis. There are some structures you run into. So if it's a female patient, you'll run into round ligament, which we usually ligate. If it's a male patient, we'll encircle the cord structures and with a vessel loop and kind of get them out of the way under the retractors. And then in both males and females, we'll ligate the epigastrics to help us with exposure.
Sometimes, like we talked about before, if you know you already have some strange vasculature or multiple arteries, sometimes you can leave epigastrics as a point to anastomose arteries, but it's kind of a rarity. But that might be one case where you wouldn't necessarily want to take them ahead of time, but that you would probably know that ahead of time.
So you might do an anastomosis to the epigastrics. Is that what you're saying?
It's been done, especially with lower pole vessels, since that's very important. If there's any sort of injury to that, the lower pole supply is really your ureter, and you wouldn't want to accidentally remove that vascular supply. It can be done. It can be a nice little trick, but you would know that ahead of time from looking at your kidney, back tabling it, and knowing what vessels you have.
And then the inferior edge of our dissection is really until you feel the pubic bone and feel for the Foley balloon. And that's when you kind of know you can stop there. And once you blow up or fill up the bladder, you'll be able to identify it there. So once we've placed our retractors, we begin with our external iliac artery dissection and mobilize it circumferentially. And usually the external iliac doesn't have any branches, so you can get around the artery with the Penrose and then just take down the attachments from it with Bovie. Some people like to suture ligate these attachments as there may be some lymphatics here as well. And we do this both superiorly and inferiorly along the length of the artery so that we're able to medialize it if necessary.
Some of the things you always look out for, there's usually a vein running across the artery very distally. You want to make sure and control that. It can be a difficult place to control if you accidentally come across it and don't have good control. But other than that, getting good length on both of those vessels, both the artery and vein, really helps you once you have your kidney in place and are getting everything positioned, so you don't have any kinking and torquing for your anastomoses.
Yeah, sometimes we'll use a Satinsky clamp just to kind of see how our clamping would be and if there's enough mobilization or length in both vessels as we're trying to get around them and dissect them superiorly and inferiorly, just to make sure that the exposure is good, because that is definitely the key in this operation in the start. And I will say, like, if patients have had prior appendectomy or maybe had a perforated appendix, this plane and this dissection can sometimes be very difficult, and sometimes the vein is hard to peel off and mobilize from the peritoneum as well. Usually the dissection around the vein you can do bluntly with like even a suction and to just try and get around it. But if they've had prior operations in this area or inflammatory reactions, this can be a little difficult.
Is that a reason you may choose to go on the left side from the get-go? Or do you usually give it a shot on the right and see what you come up against?
In my experience, we usually give it a shot. Have you guys steered away?
No, I mean, the right can just be so much easier as far as how superficial the vessels are compared to the left, especially if you have a deep patient or obese patient. I would want to give it a shot unless I were very concerned.
How many centimeters would you say you're mobilizing of both those vessels on average, just to give our viewers an idea of how much is needed for a good anastomosis?
I would say it really depends on how everything looks. You've looked at your kidney. If you have a living donor kidney, you're going to have a shorter artery and vein on that kidney, so you might want more mobilization. If you have very long artery and vein on a deceased donor kidney, you might not need as much. I have the preference of basically mobilizing almost the entire external, because I want a lot of leeway. I'm sure there are people that don't like to do that. I think it's really independent of whoever's doing the operation.
So the kidney usually comes on ice. Some people like to put a lap pad around the kidney just to keep it cold while we're doing the anastomosis. Some don't, but once the vessels are exposed and there's good hemostasis, we're usually ready for the anastomosis.
Why don't you take us through it? Which one are you starting with first?
So we usually start with the vein first. We'll place a Satinsky clamp around the external iliac vein, make a venotomy with the size of our donor vein, and then use heparin infused saline just to flush out the vein and make sure that it's clear. It kind of helps us clear out any leftover blood in the vein and also see if there's any kind of collaterals that are still feeding that vein if we need to reposition our clamping. And then after that, we start with the anastomosis, usually with a 5-0 or a 6-0 double arm proline. We set both corners and tie them down, and then sew the lateral side first and then the medial. Once the vein is done circumferentially, we'll clamp the renal vein with we usually used a Garbodi, which is just a shorter version of the Satinsky clamp. There's different variations of this, and kind of release the external iliac to check the anastomosis, but not reperfuse the kidney entirely. And then we'll leave the renal vein clamp while we sew the artery.
Okay.
So just to help visualize, this is an end to side anastomosis.
Yeah, and so how exactly are you clamping with the Satinsky? For our listeners, what does it look like? The vessel after it's been clamped, and
So the way I think, oh, go ahead.
No, go ahead. You might be better able to explain this, how it looks.
So first off, just for what a Satinsky looks like, basically I kind of think of the Satinsky almost looking like a little dipper. There's basically a square bottom and then a handle that comes off one side. And when you clamp the external vein, you're going to have the clamp coming off distally, so towards the feet. And then the little tip, the little part of the square will go off towards the head. And that way the vein is between these 2 points. And that bottom connecting point of the square is underneath the vein. That way you have both distal and proximal control with one clamp. And then when you take that off, after you've made your anastomosis, you put on a smaller clamp on the renal vein. And that way you don't get that warm blood shooting up back towards the kidney. Some people don't use a Satinsky. Some people use 2 independent clamps and don't even take it off at that point. It's just a style preference.
okay,
If that helps.
it does. Thank you.
I will say that some people medialize the artery before they sew in the vein. And some people only do that depending on if they're sewing in a right kidney or left kidney, but other places routinely medialize the artery. So that just means it's a little bit easier to sew the artery anastomosis after the vein has been sewn because it's kind of medialized to the other side of the vein, whereas usually it would be more lateral.
And where's the donor kidney sitting while you're doing all this?
Who's the surgeon? So sometimes some people make a kidney sock. Some people put the kidney in a little sling that's made of a lap. Some people put the kidney down in the abdomen and put ice packs by the kidney. Whatever we're doing, we're trying to sew quickly to minimize our warm ischemic time, meaning while the kidney is, not fully on ice and not reperfused. And we're trying to keep it as cold as we can somehow.
Okay. So you've finished your venous anastomosis. That renal vein clamp remains on so that you don't have any of that warm refluxing blood going into the kidney and harming that warm ischemia time that you're talking about. Tell us about the artery now.
So the artery, we use the same Satinsky clamp. We want to make sure we have proximal and distal control with that clamp to clamp around the artery, and we make an arteriotomy. And then here we use, so we flush out the artery with the hep saline flush as well. And then here we use an punch to make kind of a circumferential hole with the size of the donor artery. And this is just single hole punch. If you can imagine like a 3-hole punch, it's just a single hole punch. Then we make a hole into the artery on the anterior aspect. And then we create an anastomosis here. If it's a deceased donor kidney, sometimes you have a corral patch or an aortic patch or cuff that you can use to create an anastomosis here. We usually do it with a 6-0 proline. And there are many different ways to do this anastomosis. Sometimes you can parachute this anastomosis, and sometimes you can also set the corners and circumferentially sew, starting from the lateral side and then the medial. Everyone has a different way and a set way of doing the artery. So there are a lot of variations here, even more than the vein, I think. And then towards the end of the arterial anastomosis, we usually give a couple of medications or have anesthesia give them. Usually it's Lasix and mannitol. At our institution, we give 100 milligrams of Lasix and 12 and a half of mannitol, but the dose is not standard and varies depending on where you're at.
And what's the purpose of those medications?
To help jumpstart the kidney when you reperfuse and to kind of flush out any kind of toxins or anything when you reperfuse as well.
Any other notes about the arterial anastomosis?
I think it's important to look at the vessels of both your donor and the recipient artery. You don't want to be sewing where you're pushing plaque out. You want to be, if you have plaque sitting in the recipient vessel, you want to sew so you're kind of securing the plaque as opposed to pushing the plaque out just for the direction that you're sewing is one thing I tend to look at, because some of our patients have pretty diseased vessels, and sometimes you even get a donor kidney with some diseased vessels. So just looking at that when you're sewing.
The difference in a deceased donor kidney and a living donor, I don't know if Anushi said this, but the deceased donors have a Correll patch, which is a little bit of aorta cuff that we're able to keep on to the deceased donor artery, and that allows a bigger patch to sew to. Obviously, the living donor kidneys don't have a patch of the aorta attached to them. And so they're it's just a tube that is being sewn down. And so the anastomosis is a bit smaller for the living donors.
Do you have to spatulate the end of that living donor in order to accomplish that, or you just manage to get it in?
We don't spatulate, we just sew it straight in.
Very cool. And then, that leaves one tube left. How do you guys handle the ureter?
So before the ureter, we reperfuse the entire kidney. So we take off both clamps and reperfuse the kidney and see how the kidney reperfuses. Dr. Diapher will always say that I'm a little spoiled because I've participated in more living donors than deceased donors. So I'm really used to pink kidneys. So whenever I do the deceased donors and I don't see them being pink right away, I just have this look on my face. But we wait for it to reperfuse, see how it reperfuses, look at all the sides, achieve any kind of hemostasis, and make sure to check in with the anesthesia to make sure the patient is stable. And then we'll take a breather and move on to the ureter. So we will ask anesthesia to clamp the Foley where the Foley sits by the head by anesthesia. And then we will ask the circulators to infuse the antibiotic solution that we had prepared at the start of the case that was attached to the Foley, and let the bladder kind of fill about 200 cc's or so, between 200 and 300 cc's. Usually you can feel the Foley balloon if you just feel for the pubic bone, and you'll feel the Foley balloon, and then you can easily kind of identify or see the bulge of the bladder into your field. Sometimes it's not very obvious, especially in patients that have not made a lot of urine and have really small bladders or thick bladder wall. And so sometimes you can use a 30 gauge needle and just stick the needle into the area where you think the bladder is and aspirate and look for blue, which is another reason why we use the blue solution, so that it doesn't get confused with any kind of peritoneal fluid. All right. So then after that, we prepare the ureter. So we'll look at the length of the ureter. We want to ideally keep shorter segments to kind of minimize the kinking of the ureter and also ischemia. So like Dr. Aaron mentioned before, the ureter is supplied by any kind of lower pole vessels. We don't have any other blood supply to the ureter. And when we are I'll just throw a plug in that we didn't mention earlier when we back tabled. We also look at the ureter to make sure it's not stripped completely of surrounding tissue or adventitia around it, because that's where the blood supply to the ureter kind of runs as well. And so we don't free off any tissue around the ureter when we're preparing it at the back table. And So when we bring it into the field and are ready to anastomose the ureter, we kind of look at the length between the renal pelvis and the bladder and try to get as short of a segment as possible. And the blood supply to the ureter is at 3 and 9 o'clock positions. And so we tie off the vessels at the end there. And then we're ready to spatulate the posterior aspect of the ureter and how it would sit on the bladder. So we only spatulate or cut down the posterior aspect about 2 to 3 centimeters after looking at how it would sit on the bladder.
And you want to see nice bleeding edges, so you know that part of the ureter is nice and well perfused.
Yeah, and then once we are happy with the positioning, then we move to open up the bladder. So the way it would sit, we would use Bovi to open up the bladder, and we dissect judiciously all the muscles, the trusor muscle, all the way down to the bladder mucosa, and you'll see the mucosa bulge. So we take this down layer by layer, and you can see the blue filled bladder under the mucosal bulge. And so we just have the mucosal layer because you want this to be a mucosa to mucosa anastomosis to make it watertight. And so once we see the mucosa bulge out, then we get ready to open up the bladder. And we open up the bladder with scissors and then start to create the anastomosis. And the way we do this is with the 6-0. We use Maxon, some people use PDS, and we sew heel to toe. So you can imagine how the ureter would sit on the bladder with the spatulated ends kind of touching the bladder mucosa. So we sew heel to toe. The heel is more important. And so we make sure that we take small bites around the heel so that you don't catch the back wall and avoid any kind of stricturing of the ureter. So small bites at the heel, and you can take larger bites as you come around the toe. And then at the end of that, we test it for any leaks by having them instill more of the blue solution. And so that if it leaks, we'll see any kind of blue leaking around the anastomosis that we can fix.
Are you guys placing stents across this anastomosis?
Good question. So we don't routinely place stents, but it's more patient dependent. So if it's a very small size ureter, or if for some reason, if the patient wasn't making a lot of urine and the bladder was very small, we can sometimes place a stent in. Or if we were worried that the lower pole vessel was maybe potentially compromised during the procurement, then we would place a stent in case there is possibility of some ischemia or stricturing of the ureter, but it's very much dependent on the case-by-case basis.
There are certainly places that routinely always place a stent. It just depends on your institution.
If you were to place a stent, how would you do it, in the course of that anastomosis?
Yeah, so we would sew one side, and then before sewing the other side, you would feed a stent over a wire proximally into the renal pelvis first, and then take out the wire and use kind of two DeBakey's to feed in the distal part of the stent into the bladder. And it's a double J stent, so it'll just curl into the bladder and not fall out as you're putting it in.
And once you're done with that, mucosa to mucosa connection, how do you close the muscle layer?
So we close the muscularis layer of the bladder over the toe of the spatulated ureter to kind of create a reflux tunnel. A non-reflux tunnel. And we do this with multiple interrupted fivovical sutures, but that varies with institution.
Is there anything in particular that are musts when it comes to the suture choices that you're making for for these 2 layers, or does anything go?
I don't think so, as long as it's an absorbable suture, and this is a loose tie as well. You don't want to tie down completely onto the ureter and stricture the ureter there as well.
Why absorbable versus non-absorbable?
You don't want a nidus for stone formation, is how I've always thought of it. Just like when you're doing a bile duct.
Okay, what comes next in the steps?
After that, we're ready to close. We just make sure that there is good hemostasis. Sometimes we would, this is where we would decide if we need to leave a drain. We don't do it routinely, but if the patient is high risk for bleeding, if they're on anticoagulation, or if there's going to be a need of anticoagulation postoperatively just because of their other comorbidities, or if the tissues were friable and there was diffuse oozing throughout the case, and we were worried that there may be a hematoma that would form post-op that may have some compression on the kidney, we would then leave a drain around the perinephric space here. So this is where we'd put the drain, but other than that, we just make sure there's good hemostasis and then we'd be ready to close.
Some people routinely drain to avoid the creation of a lymphocyte, which is another complication that can happen with a kidney transplant. And so if you're not meticulous in tying off all of the lymphatics, or even if you are, you can develop a collection of lymph. And so a lot of places choose to routinely drain, and then they can monitor the drain output and pull it when it's diminished enough that they're less concerned about a lymphocyte. There's no data that I'm aware of that leaving the drain prevents the lymphocyte, but that's another reason some people leave it.
Okay, so your patient, comes out of the operating room. You've accomplished this surgery. Technically a success. What does the post-op monitoring look like? This is something that I think is especially relevant to the general listeners out there, because we're not all going to be doing the kidney transplant, but we should know a little bit something about how to manage these patients.
Yeah, so every institution has their own protocol for how they manage post-op kidneys. For us, we routinely get an ultrasound in PACU right away just to evaluate the arterial and venous flows and look for any kind of perinephric fluid collection, hematomas. Also, you want to make sure that you follow strict I's and O's, especially if the kidney is making urine, and also have good hemodynamic control. Low blood pressure is no good for kidneys, but also blood pressure too high is not good and can lead to formations of hematomas or bleeding that's unexpected. And then the basic resuscitation principles kind of follow here. A lot of times with living donor transplants, for example, the kidney's working right away and makes a lot of urine, especially in patients that's not used to having any urine at all. You want to make sure that you are able to keep up with their output. And so we match our I's and O's with IV fluids hourly, especially the first 24 hours, so that we can keep up with how much they're putting out in terms of urine output. But you just want to make sure that the patient gets well resuscitated and has stable hemodynamics, and that the ultrasound waveforms are okay.
How often do you get the labs?
So we get labs post-op, and then 4 hours post-op, and then the next day. But that is also depends on the institution and their practices.
So I'm going to ask you, Anushi, what do you want these residents to do if the patient has no urine output for an hour or two after their transplant? What do you want them to check before they call you, or do for the patient before they call you?
Yeah, so it's important to know if the kidney made any urine post reperfusion at all, or if this was a deceased donor or a living donor. You want to make sure you go and examine the patient, which is a routine given. And After that, check their hemodynamics and then check their Foley. We don't like to, or I don't like to flush the Foley right away, but to make sure that it's not externally kinked or compressed. And then check the ultrasound or repeat ultrasound if you need to evaluate for most commonly renal vein thrombus can cause no decrease in urine output or abrupt decrease or no urine output postoperatively. And that is one of the biggest things that we look for post-op.
And sometimes you'll just have to flush the Foley, especially if you're seeing that there's urine in the bladder and it's not coming out. A lot of times, if you had a particularly bloody anastomosis or the patient's on anticoagulation, they definitely can get a blood clot inside their bladder that can be blocking the Foley. You'll just have to flush it with 10, 20 cc's. You'll probably feel more comfortable if you do it yourself, but sometimes you just have to do it just to make sure.
And a bladder scan can be useful. That's what you were implying, that there's a bladder scan shows that there's fluid in the bladder, but it's not coming out in the Foley. And that would give you a tip that maybe there's a clot in the Foley. And I just think it's important too on the post-op labs, especially if you have a kidney that's a deceased after cardiac death donor kidney, that those oftentimes do not work right away, and the patients may have a high potassium. So it is important to keep an eye on those labs, not only to follow the creatinine, but to make sure you're following the potassium and to see if you need to call your nephrology friend for some dialysis.
Are there any special considerations for dialysis after a kidney transplant? Like, is there something that the nephrologists are doing specifically because there's a newly transplanted kidney, or is it pretty standard dialysis?
Well, we try not to remove too much volume. You actually want to keep them a little bit above their dry weight. You want the kidney really well perfused. You certainly don't want them dehydrated. So we try not to dialyze just for volume. So sometimes in the operating room, we have a close communication. Well, actually always in the operating room, a close communication with our anesthesiologist. Like, do we expect this kidney to work and they'll pee? Or do we have to be really careful about how much volume we're giving them? So we don't want to put them through kind of the hemodynamic trauma of dialysis if it's just for volume. If it's potassium, it is what it is. So we need to keep them safe, but we try not to just for volume.
What is the history of the placement of the transplanted kidney? Right now we're replacing them retroperitoneally in the groin. Has it always been the case? And what's the evolution of that placement been?
So it hasn't always traditionally been the way we do it. You can certainly hook up the arterial and venous anastomosis almost anywhere along your aorta, your IVC. It's just a matter of so much of the ureter. You can do a UU and do that traditionally just to the native ureter. You can do a nephrectomy, and people have done that in the past. This institution did that in the past. They would do a nephrectomy and connect the ureter directly to the native ureter. It's certainly much easier, we found, to be close to the bladder, that short segment of ureter. So that was an evolution. Another evolution has been kind of the placement left versus right, and depending on which kidney. A number of years ago, I think maybe 20 years ago, it was more of a tradition. If you had a left kidney, you'd place it on the right, and a right kidney placed on the left, so that the renal pelvis and the ureter were more anterior in case you needed to do some work on there. You had a stenosis, but that's been changed since that has decreased as far as an operative intervention, and now traditionally just on the right as choice, given how easy it is, comparatively easy with the vessels and the exposure. There might be more history that I'm not aware of.
Any last remarks about the kidney transplant? This has been really good so far.
I have to take a moment to remark that I, as the faculty here, did not need to be in attendance, and I'm incredibly proud of these two fellows who really did a remarkable job describing for you what a kidney transplant would be. And I would also like to note, I don't know when this is airing, but it is Women's History Month, and that you're listening to a podcast of 3 women transplant surgeons. So I think transplant is a phenomenal career. It's an opportunity to make people's lives incredibly different. It's fun, it's unique. There's so much research that needs to be done. No matter what your research agenda is, if you're a basic scientist, a health outcomes researcher, if you're an ethicist, if you're into politics and policy, transplant really has it all for you, and it's a great field for women.
Well, I couldn't really end the substance of the episode any better than Dr. Daggerford, so I left it at that. I think this was a really phenomenal instructional from literally a select few of the nation's best transplant surgeons, and I couldn't be more honored that these 3 women took the time to talk with me on the podcast. Hey, so this was our first video-based episode that really drilled in on surgical technique. If you loved it as much as I did, please visit our YouTube page if you're not already watching this on YouTube. Find this video podcast on our channel and give it a like. And don't forget to subscribe to the YouTube channel as well, because we have a lot of good content on there that you don't find on the podcast proper. And most importantly, if you think you've got a good expert experience on a particular surgical operation and you can also get us good video of your technique, reach out to us at btkpodcast@gmail.com. We'd love to have you on the podcast to do another episode like this. Until next time, dominate the day.